Okay, welcome everybody. It's 12:30. We are here for a nice webinar organized by the European Forum for Primary Care. For those who are not familiar with the European Forum for Primary Care, just in a nutshell, we bring all stakeholders within primary care, academics, policymakers, practitioners, patients, informal carers together to discuss the organization of primary care, to have the best output, the best results, the best health care for the populations in need in Europe. And part of this is, of course, this issue of medical deserts, in particularly in areas where, populations are having scarce access to healthcare. There is a problem. And the European Commission also recognized this, so they have financed a couple of projects, and two of them will be presented with results and with some suggestions for possible solutions. And the persons who will do this today are Linda Flinterman. She's working at the NIVEL Institute in the Netherlands. Background of biomedical science, but quickly going into public health as a public health researcher for almost 10 years now at NIVEL. And she will present the ROUTE-HWF workforce project, and will share with us the factors of medical deserts in Europe, and a focus on the Netherlands, Spain, Croatia, Poland, Germany, and Ireland. And then second will be Corinne Hinlopen. Corinne and I, we know each other already for 20 years when we did our masters in public health, international masters in Holland. And now since 2014, she's working at WEMOS, at the International Health Department. And she will look into the AHEAD project and give us a view on solutions to medical deserts at local, national, or European level. So having said this, I would like to give the floor to first to Linda, and then I'm looking forward to your presentation. Thanks a lot. Go ahead.
Thank you, Dirk, for the introduction. I will share my screen, see if I can find my presentation for you. No, first slide is better. You should be able to see it now. Good afternoon, everyone. As Diederik already told you, the ROUTE-HWF project was a collaboration between 5 institutes. So the NIVEL from the Netherlands, the University of Zagreb from Croatia, the University of Krakow from Poland, the Vasa University in Finland, and the Donabedian Institute in Spain. And the ROUTE project stands for a roadmap out of medical deserts into supportive health workforce initiatives and policies. And in this, as the title says, we developed a roadmap which should help countries to at least get a little bit less medical deserts in their country, or to solve some of the problems. Let's see if why doesn't my thing work now? Yes. First, shortly, the approach of our project. We finished last February, so we finished our project. So we did some things in the project, of course. We did a literature review. We had country expert consultations in the countries that we are from as consortium, so the 5 countries we mentioned before. We did develop a taxonomy, which I will explain to you in a few minutes. We did some case studies in 6 countries. We had a consensus meeting on the taxonomy and also on the roadmap in Zagreb. And at the end of the project, we developed a roadmap, which I will mainly present today. And the aim and the result of our project was that we wanted to identify if there's just one definition of medical deserts, or do we have more? And our conclusion is there are more of them. It's not one type of medical deserts. That really depends on the country and where you are. And that's because they come from different types of developments. And to deal with these different types of medical deserts and different problems, there are also different solutions and different types of routes that you should take to reduce the amount of desertification in your country. So the main result of our study was the roadmap, which I know the typo is too small here. I will get you through it in the next few slides, but it's a 9-step approach, the roadmap, and as you can see, it's circular. So if you are all the way around, you start again. That's the idea. So you finish the circle, and then by starting the circle again, you can see if you have improvements and if you should do more, or that you are finished and you don't have medical deserts anymore in your country. So to start with step 1 from our roadmap is first of all get some data. Find data to understand the current state of health workforce distribution in your country. And also you need some data to be able to identify medical deserts in your country. Probably most people have some idea of what areas in the country might be better off than others, but to have some idea of how bad it is and how much you can improve it, some data can be useful. And also, as a first step, you have to think about at what regional level do you have data, and at what level do you want to identify the medical deserts. And that's one of the things that we found out also in the project. You have a lot of regional divisions in different countries, but the region should not be too big, but also not be too small. And you need to have data on that regional level. So that might make it a little bit difficult, but the main thing we found out, you don't want to have too big regions, because within a big region, there are still areas of that region that are doing fine maybe, and other regions that are not. So decide on a good level on which you want to collect the data and want to compare it within your country. So that was step 1. So we have data, we have an idea of how our country looks like, and how do we define then the medical deserts in this country. So this is a decision point where you determine if you have medical deserts and what types of medical deserts. And to do so, we developed in our project a taxonomy, so to identify the medical deserts. And we did this with all the case studies and with interviews in all the countries. And from those interviews and case studies, and 4 key elements came up every time, actually, which can be divided into types of elements. First, on the demand side, so how much care is needed in the region or in the country, which are mainly, actually, the main 2 reasons that came up every time was the age of the population in the region. So a higher age probably has a higher demand. And the same, the other thing was the socioeconomic status, or the poverty level, or how you want to call it in a region, also has a relation to how much the need is for care in the region. So those are the 2 objects that we identify in the taxonomy for more the demand side. So you can have a high demand in the region compared to other regions. But on the other side, you also need enough. That doesn't have to be a problem if you have enough supply in your region. So the other side, the green blobs on the below, are the supply elements that we are looking into. The first one is quite obvious. How much healthcare workers do you have in the region compared to the number of people that are living in the region? So do you have enough workforce there, or do you need more? And the other one is the accessibility to healthcare. So you can have maybe enough people, but if they're not divided in a good way over the region, or if the accessibility with public transportation is not good, or the roads are not good, then that also might be a problem to get to the healthcare. So these are the 4 main elements that go in our taxonomy. And to become a medical desert, you really need elements on both sides. So both the demand should be higher on average, and the supply should be lower, or the accessibility should be lower on average. And then if you combine these 4, then we define 4 types of medical deserts in our project. And from the 4 types of elements, the one that you have a low ratio of professionals compared to the population is always there. If you don't have that problem, then you don't have a medical desert. But if you then combine the 4 elements, then you have a full medical desert in which all apply. So the population age is higher in this area than compared to the country. There's a poorer economic situation, or lower socioeconomic status. They have a shortage of health workers, and accessibility of the health services is also lower than average compared to the rest of the country. So that's the full medical desert. So then if you both full demand and supply apply to the region. But you can also have combinations in which you are missing one of them. So it could be more on the demand side that you have the problems, but only have a low population provider ratio, but the accessibility might be good. But you can also have just only a more aged population or more poor population. As I said, all the objects we compare to the average level in a country, which means that you always find some regions, of course, that are below average, because per definition, half of the regions will be below average for each object. So therefore, it's also good to define some thresholds. When do you really find it that it's really too low compared to average? Because if you have a good level in your country of a health population provider ratio, for instance, so if that's already really high in your country, how much lower should it be that it's too low actually? And the same accounts for the other three objects. And that also helps to give you an idea to how much you want to improve it in the future. But that's the next step. So first, step 2, define which type of medical desert you have using these 4 objects. And then we go to step 3. So if you define what type of medical desert you have, it's more demands-based medical deserts or more supply, or do you have a full medical desert, then of course you can, based also on the 4 elements, think of policy developments or solutions for the medical desert. So if it's more that you have more elderly in a region, you can think about initiatives like telemonitoring, for instance. Poverty, you can think more at integrated health and social care models to ensure that its healthcare services are more accessible, but also affordable, for instance, for underserved populations. Of course, all these possible policy developments also depend on the situation in the country, but I guess you understand that. Also for the supply, if you want more workforce in the region, an option could be to increase the number of training spots so that you have a dedicated training spot in those areas so that people are trained there already and hopefully stay there. But of course, also an option is to improve the accessibility of the locations if that was one of your problems that you identified. Which is all easily said, just solve this. I know it's really hard to solve these things, but at least you know what you should focus on mainly if you identify the taxonomy, or if you have to really focus on all 4 of these elements actually. So that's step 4 also, combine and prioritize policy solutions. You can't do everything at once, but might be able to combine some things, which might also help to improve it even further. So if you can solve more things at the same time. So think at the more multi-phase approach within medicines, but also in supply, but also the infrastructure solutions, which are mainly also probably a lot of medical deserts. Not that many roads, it's hard to get there. So if you can solve that, it might also impact on other things, not even only healthcare, but maybe also on other things in that region. And also strategic allocation is also one thing I already mentioned in the previous step. Encourage local medical students to stay there and also teach them in the area where they are, where you need them actually. Then step 5 is make sure everybody knows about this. So enhance public awareness and engagement. The pictures are from a campaign in the Netherlands to get GPs to the province of Zeeland, which is also one type of medical desert in the Netherlands. And this step is about engage the public and engage the people who it concerns to the awareness that people are needed in that area, and it might be nice to live actually in those areas. So the Dutch example is that they created a kind of introductory weekend for GPs and their families in Zeeland. So they got a house there, they were able to look at the GP office and get to know the area a bit better also with their families, because they have to move with them if they go there. So that was step 5. If we go then to step 6, you have thought of all this kind of policy options and you have thought of campaigns. And then, of course, you have to implement really the policy options and also do some monitoring. The implementation, I think, is straightforward, but the monitoring is also something that we discovered when we also did all the research, also the literature reviews. There are a lot of initiatives done within this field. A lot of countries try to improve medical deserts to get more people working there, more people living there, and get there more facilities. But there's not a lot of monitoring done on it, or at least there are not that many studies that show, okay, we did this now for 5 years, and now we indeed have so many more. Now we have results. We did start a training location in a certain area, and now we have more doctors in the area because of it. So monitoring is in that sense really important, also to see if what you are doing is having effects, and if you should continue it, or that you should try something else if it's not working. So it seems obvious, but it is really an important step that is, for as far as we could find in the literature, is often forgotten actually. Step 7 is also do not only look at your own country, but also look in a wider perspective. It says EU-wide now because, yeah, of course, it was an European project. But it is, I think, important because a lot of countries in Europe, although we are all different, we are all really similar if you look at these kind of problems that we have. And of course, the Netherlands is a much smaller country compared to Germany or Spain, and the difficulties we have with medical tests are on a completely different scale than in those other countries. But still, we can learn from each other. Something that worked in Spain might also work in the Netherlands, and the other way around. And we do this kind of collaboration already within, as Diederik already told, the EU financed 5 projects among medical testers, of which ROUTE and WEMOS, which Corinne will talk about, are 2 of them. But together with these 5 projects, we all shared insights on health workforce strategies and how to mitigate the medical deserts. So that's one way that there's worked on, at least to try to get the knowledge from different countries in all the countries. But we also see it on a smaller scale already. For instance, in the Netherlands, around the border areas, in a lot of countries, actually, the border areas are medical deserts, if they have medical deserts. And countries around on the 2 sides of the border, of course, can collaborate as well. And as far as I know, also in the Netherlands, this happens between, for instance, Belgium and Zeeuws-Vlaanderen in the Netherlands, which is better reachable for the people in Zeeuws. Belgium is better reachable for the people in Zeeuws-Vlaanderen than the Netherlands is. So they can use the Belgium health system. There are rules for that now, that they can use the health system there, which makes it less necessary for us to have enough doctors there. But that could be a solution. So work together also across borders. If one has enough doctors, then you can solve the problem with someone else. Then step 8, you're almost there. We're 9 steps. Step 8, the long-term sustainability, which is also about, of course, we are researchers, do some research also about this. So think about how new innovative ideas to do training, education, but also how to improve infrastructure, for instance, to ensure the sustainable healthcare solutions in those regions. And focus then on sustainable solutions so that we can use for a longer period of time, and also in this case test if do they work and adjust if they don't. So for instance, future plans could be expanding telehealth infrastructure. In some countries it might be even getting a good internet connection in all regions. It depends really on countries, but that would be already a first step to be more reachable in all regions. But also integrating health and social care services, so that also strengthens the community of health networks. So then the last step is policy adaptation and reassessment. So it should be continuously reviewed, what I said before, and of course also the policy solutions should also evolve with all the other healthcare dynamics that there are, but also the other way around, the healthcare dynamics probably also with the new policies if there's a new government or whatever. So it is a cyclical process. So that's also why our roadmap is cyclical. So you do all the steps and then you start over again, see did it work? Do I have a better, if you look at the data again, do I have a better distribution of health workers in my country now, and how much did it improve? And here on the slide are also some examples from Spain, actually, that I got from my colleague. So Spain employs an iterative process for policy evaluation and adaptation, and that's based on outcomes feedback and evolving healthcare needs. So they do have a system there to constantly evaluate and adapt if needed. And then an example is the telehealth service post during the COVID pandemic, and adapting then the workforce policies for more flexible working conditions. So that was our roadmap. So 9 steps, do it over and over again. Maybe you don't need all 9 steps every time, but I think the main message is do evaluate, do see if things work, because there's not one size fits all solution, unfortunately. So there's not one thing you can do to solve all the medical desks in your country. So keep close to it and look at what you can do. And this is what I was about to tell. You can find all our information, the roadmap, but also the case studies and all the other publications that we have at our website. So please take a look also there maybe afterwards. And of course, you can always reach us also if you need more information about the roadmap or about our project.
Linda, thanks. There was already the question, where are the publications? So I put in the chat the link to your website where you can also find the publications. I did the same for a hat, but then I did the wrong one. But Corinne was sending the good one. So that's sorry for that, Corinne. I was a bit too quick. But there you can also find everything on a hat, which is now coming up. But there is already a question, and I think it might be good to have a look at it already. And I have one other question myself. But first, the one of Martino Canonico from Italy. So digitalization as a key ally, which is a conclusion already. Is it a key ally? But anyhow, you say it's a key ally for helping grant patients access to healthcare and beyond telemonitoring. Maybe, Martino, what do you mean with e-health digitalization beyond telemonitoring? What else do you think on other than telemonitoring are at stake? Can you open your mic and say something?
Yes, thank you for this opportunity, and perhaps I'll also turn on my camera as well so you can see me.
Good.
Thank you very much. I represent indeed a sector which is the online pharmacy one, and of course we look a lot into the opportunity for patients to access pharmacy services remotely, and as you can imagine, we collaborate a lot with people that have difficulties reaching the closest pharmacy, or simply get monitoring during the day as to their pills. Management taking, teleconsultation for any kind of information as to the kind of illness that they have developed, and also how to take, for instance, asthma medical devices. So for all these things, I think we are only using 5 to 10% of the potential of digitalization. And I think Linda rightfully mentioned the importance of facilitating access to physical venues, healthcare venues specifically. I think there's also a chance to somehow raise the awareness of what can be done remotely. On the one hand, to avoid creating additional burden on the healthcare workforce, and on the other hand, to facilitate these people that might sometimes have difficulties really reaching physically the place of healthcare. So my question was, have you developed also some other recommendation as to, for instance, delivery of medication at home, teleconsultation, any other kind of telepharmacy service that nowadays is possible in the Netherlands especially? Thank you.
In this project, we didn't really develop these kind of solutions. We mostly collected them and showed them in the case studies and in our reports what countries are doing, with the idea that countries can learn from each other. But indeed, the telemonitoring and telehealth or e-health, or how you want to call it, is of course a thing that is used in a lot of countries, also in the Netherlands. No, it's not a difficulty. what you mentioned, you are in pharmacy, and I think it's also really different how much e-health or things you can use depending on what kind of health workers you're looking at for medical deserts. I think we mainly focused on general practitioners. The taxonomy, I think it works for all types of health workers. You could also do it for hospitals. But GPs, of course, they can do a lot with e-health, but they might want to see their patients every now and then. For pharmacy, I can imagine that's a different balance between the two. So I think that also policymakers, or if you go to work with this, you should think about, okay, what type of health workforce am I looking at and what should work for this type? And then, of course, e-health could be a big part of it, especially, I think, also in pharmacy where it's easier to do things in that way.
To play the devil's advocate, I'm just thinking from out of the perspective of the EUREPA group, which are the remote GPs, Martino, and they say clearly a face-to-face contact is always needed. Full stop. It's nice to have this digitalization, but we as a GP, we need this physical contact. So Martino, can you live with that approach?
Oh, absolutely. I think, there shouldn't be either one of them. It should be a complementary solution. Huh? I mean, we are not saying, one of the two should fit all the occasions, all the needs from both the GP, but also from the patient side. And as Linda said, pharmacy and doctors and physicians are two different practices, so two different solutions apply. I can tell you that from what we see operating with the patients that are using online pharmacy services, especially, as I said earlier, there's still a bit more that can be done in terms of offering the opportunity to use digitalization, which again should be, in my opinion, just a choice, freedom of choice to decide in that case what can be used, if it's a digital solution or, as you said, if a face-to-face service is needed, because most of the time this is the case. Let's not forget that this should not, as I said, this should not substitute the face-to-face and physical contact. But as I said, it doesn't mean that we can't do more with digitalization, also for healthcare workforce. And most of the pharmacies nowadays spend a lot of time doing administrative, for instance, tasks and so on. They could do more for the patient itself. So yeah, these are just my 2 cents. Thank you.
I think Corinne will say a few more about what can be used. What are the solutions on this digitalization, also for elderly? That's a difficult group in that respect. My question quickly is about the intersectoral collaboration in this respect, as I think the desertification of health is not standing in its own. You have the grocery, the shops disappearing.
Buses disappearing, yeah.
So I think there, Linda, did you look at that aspect as well within your whole setup of circular interventions?
In a sense, it's part of our taxonomy because of the accessibility of healthcare, and that's it comes together a little bit with that the literary accessibility. Is there a bus going there, for instance, from the street where you're living? But that is indeed a sign of the desertification of certain areas in all aspects indeed. So in that shop first, I think the healthcare is the last thing that leaves, actually. I think first the shops stop and first the bus leaves, and then the healthcare is, we can't sit here anymore because we don't have any resources anymore, so they have to move as well. So ideally you would stop you won't have a medical desk if you can stop it before that. So if you can make sure that the resources stay in any region or stop it when they start to move out. So if the first shops close, you should getting worried.
yeah, exactly.
But okay, I know in a lot of regions, I live in such a region myself, that's already too late. You won't ever get them back, I think. But a bus stop would be nice to get around.
Yeah. Okay, Corinne, the floor is yours.
Okay, let me check. You can hear me okay?
Yeah.
Fantastic. I'll share my screen then. It's not going into presentation mode, is it?
Not yet.
Yes, but now it
Yeah.
is, right?
There it is.
Okay, fantastic. Hi, good afternoon, everybody. It's really nice to be here. Yeah, my name is Corinne Hinlopen. I have been introduced by Diederik. I work at WEMOS, and WEMOS was the lead partner in the AHEAD consortium, and the AHEAD consortium consisted of the organizations whose logos you see at the bottom of this slide. So this includes the School for Public Health in Moldova, the Free University here in Amsterdam, our academic partner, Cittadinanza Attiva, or Active Citizens Network in Italy, the Center for Health Policies and Services in Romania, and the Media Education Center in Serbia as our communication partner. This presentation I will touch on three things. I will quickly whiz through our unique selling points. One of the unique selling points is the consensus building methodology. So that's my second part. I will dwell longer on that one because it's really an interesting approach, I find, that could also be very interesting to the audience today. And I will indeed also go into the policy options that were developed on the basis of the or through the consensus consensus building methodology. Sorry. USP 1. Our unique selling point number 1 was the medical deserts diagnostic tool. I'm assuming actually that you will get the presentation later, so you will also have access to the links, the hyperlinks that I'm including in the presentation. So one of the nice things that we developed was this visual tool, medical desert diagnostic tool, which shows you, and this is just a map with where the countries are highlighted, but this is not what a diagnostics tool looked like, but it visualizes different indicators that are related to medical deserts in the 5 countries. So you, if you go to the link later, then you will see maps with different colors depicting different densities of different professions and health or care workers. So it's a great conversation starter to have this diagnostic tool because you have a visual tool to point out to policymakers what actually the problem is and where the problem is. Our second was then, as I said, the consensus building methodology that I will dive into later. And the third one was this one. We developed policy options, of course, and we summarize them into a call to action that we subsequently presented also during an event in the European Parliament. And in that event, we called on the different actors, including at the EU level, to implement the policy interventions, everyone in their own mandate and scope, and also to work together across the silos, so to speak, in synergy to tackle the challenging societal phenomenon that a medical desert is. We just heard Linda and Diederik also touch upon more aspects of medical deserts than just the medical. So we are very proud to have had that event in the European Parliament, and I wanted to highlight this as well. Those were the USPs. Now, this one, the consensus building methodology. What is consensus building in the AHEAD project? First of all, it's a social process of obtaining a general agreement among relevant stakeholders on policy options to counteract and prevent medical deserts. It's a social process. That means that you have to get lots of people around tables to start talking with each other in order to, at some point, reach a general agreement. So we're not focusing on the, as a starter, on the medical sector, for example. We treat it really as a societal phenomenon, first of all. Then second, it does not necessarily mean that all stakeholders have to agree with each other in every respect. You can agree to disagree. What you strive for is that at some point you reach a consensus on, okay, this is a road that we should take together in order to solve this medical desert problem. And okay, you have a different take on it than I do. I would choose something different, but we can find consensus on something that we share that we think could work. That's the second. The third one, As a head consortium, we focus on building consensus on policy options that focus on a wide range of locally developed innovative solutions. The wide range is important. It's not just about the GP practices or the number of nurses. There's more to it than that. There's also the transportation, for example, the transportation challenges. There's also, for example, schooling challenges. Schools are closing also because we're talking also about depopulating areas. So the fact that schools are not available anymore may actually be a sort of deterrent for new GPs to settle in some areas because they come with a family and with children. I mean, it's all there. And then we expect that, just a sec. We expect that the participatory consensus building process will lead to better decision making by involving the different stakeholders in developing better solutions. Better decisions because you have more stakeholders around the table who can each and all contribute in their own specific way, so the solutions become also better. And this is also proven by literature. This is based on scientific evidence, so to speak. Important to note here that the methodology is co-developed by Athena Institute of the Free University of Amsterdam, our academic partner. Excuse me. So why on earth would you apply a consensus building method? Because you can understand it's a time-consuming process. Well, there are different reasons for that. It enhances the options for equality. Co-created policy options are more likely to address health inequalities. Why? Because you have different stakeholders around the table, including community organizations or organizations for the elderly, for example, or organizations who represent certain subsets of your population. Second, quality, because they are co-created and there have been discussions already about the policy options and people have a shared understanding of what they entail, plus they are developed locally, they are supposed to be better, more efficient and more effective. Legitimacy is also a very important one. There's increased political trust or confidence in policies from all stakeholders because you have been co-creating them. And the politicians, the local politicians, are also around the table. So those who make the decisions are there as well. They are readily approachable also for everyone. Acceptability, the stakeholders will be more likely to accept and implement the policies. As I said, you have had the discussions, you have a shared understanding, you have the consensus, like this is going to work. Then who are the stakeholders? This is very context specific. Linda mentioned also that in the different countries where also we worked as a head project, the circumstances are hugely different. They vary widely. So who are the stakeholders when you look into the specific medical deserts? They could be any number of organizations or representatives, but normally you see stakeholders from health recipients, so community members, patients organizations. In the Netherlands, for example, I work with representatives of elderly organizations. They can be health providers, whether they be GPs or midwives or nurses or community nurses, or their representatives, because you have group practices, group GP practices in the Netherlands, and then they also form sort of a network that then has one sort of a manager or representation that could participate in the consensus building. And you have health insurance companies here in the Netherlands who have a very strong influence on how health and care are organized. So you want to have the people around the table who have an interest in access to health services and who are also have an influence on the decision maker, on the decision-making process. And the decision makers then are also not only the health insurers, but also the local governments. And through them also national policymakers, because of course national policies also affect local policies. And because these medical deserts projects were very much geared towards solving or helping solve health inequalities, we aim to especially involve underrepresented groups. And this is the step-by-step approach that we employed with the consensus building. It's a three-phase thing. First, you start organizing several single stakeholder sessions. So you invite the representatives from the community groups in one session. You have the policymakers in another session. You have the health workers and the representative in another session. So you have the single stakeholder sessions, and you explore the topic and the problem, and do we have the same understanding of what we are talking about here, and what areas we could identify as solutions as well. Then the second step, you bring representatives from the single stakeholder sessions together and sort of repeat the same process. Are we talking about the same thing? Do we have a similar understanding of what the challenges are? And then everybody brings in their own perspectives, not just the analysis phase, but also the solutions phase. And then the third step, you escalate it to a national level. So you ask representatives from the multi-stakeholder group sessions to meet with political decision makers at national level, and you focus on codifying, so to speak, the policy options developed in the previous phase. And this is important. The output is then a handout of feasible policy options to be taken forward for discussion in national dialogues and in national policymaking platforms. Now, imagine we have 5 countries in our consortium, so that we have, at some point, we have 5 handouts, and they can be, I mean, this is not one A4, huh? This could be 10, 15 A4s as lists of policy options. So those were the ones that we then collated into the call to action in the European Parliament. But this is a nice segue into the policy options. And I've heard Linda already mention a couple of things that resonate, I mean, squarely what we have found also. And I try to categorize them a little bit into 5, well, 4 basically categories, and one big container, a category which is other. But imagine that you have for 5 countries a policy options that can be 10 pages long. So it's really a wealth of information there, very rich, very context specific, very how do you say that, resonant also of how health systems function in these 5 different countries, which is also very different. So it's actually quite difficult to summarize, but again, I try to categorize them into the following categories. Now, if you look at data, we all agree we need better data, we need more data, we need better indicators, and we need to be much more active on monitoring and evaluation, especially when you start developing interventions and implementing interventions. Do they work? You want to monitor and evaluate them. Integrate these data and indicators in existing information systems on health services delivery and health outcome. They are no-brainers, but believe me, in these 5 countries, the data availability are very, very different. So again, each country needs its own specific intervention, but on the whole, yes, we need better data and more data. Then, when it comes to education, training, and special skills, increasing the numbers was mentioned almost everywhere. So the numbers of GPs, the numbers of nurses, the numbers of midwives. The situation with the scarcity in the supply, so to speak, of health and care workers is not the same in the 5 countries, but you heard it across the board. But then there is also training and updating in specific skills, and we get to the digital skills here. The providers also need to be more conversant and experienced with telehealth, telemedicine, telemonitoring, telecommunication, because there's also, especially in the elderly generation, that's what I hear. I mean, I'm one of them, but they are not very happy always, or very experienced in using digital tools. So there is actually really a need for training updates there. Then the rural health curricula. Diederik, you mentioned EUREPA. They are very strong on this. There needs to be a specific rural health curriculum for people who want to practice their health and care jobs in rural and remote areas. And then again, to make it more attractive for health and care workers to work in rural areas and to stay there, you need to invest in networks. for peer support, for mentorships, that rural health practices can come together and share their challenges, but also their experiences and their solutions. And that requires a specific effort, a dedicated effort. EUREPA is also quite strong on that one. And I heard Linda also mention train the professionals closer to medical desert areas, because history has shown, evidence shows that when you train the professionals closer to the medical desert areas, they are more prone to actually work in that area. And I know that the University of Groningen in the Netherlands has done pilots on that, but it's, I mean, this is international, there's international evidence for that as well. So don't let all the GPs be trained in the big cities, because they will never want to leave the big city with all its buzz anymore, so to speak. Very, I mean, this is very across the board. Then health systems and health workforce interventions. I mentioned already, improve attraction and retention, especially in rural and remote areas. And that can be in all sorts of ways. I heard in my consensus building session, for example, local authorities speaking like, can we not somehow financially facilitate GPs to get a good and modern practice, you know, a building to practice in? Or can we not negotiate better mortgage conditions for them so that they can actually buy a house here or want to buy a house here? All sorts of innovative angles. Then increase financial and non-financial incentives for these people. Improve overall working conditions in health and care work. I mean, this is also a no-brainer. I think we all know about the health workforce crisis in Europe. Working conditions are appalling, but of course, in rural and remote areas, there are several sort of circumstances that could make it even harder. Improve cooperation between primary and community care. So here comes in the different sectors or categories of health and care workers that operate at a rural level or in remote areas. They're not just the GPs. It could also be the community nurses or other care workers that are active and know the neighborhood. You know, how can you facilitate and improve the cooperation and the coordination between whoever is available? And that ties in with the next one. Can we not improve task shifting then among the people who are actually already working there? Mandatory deployment has also been mentioned. I put a question mark behind it because it's a sort of controversial topic. I can go into more detail if you'd like to, but yeah. It could be a solution, but there are also sorts of downsides to it. And then the mobile services, mobile pharmacies, for example, but also mobile clinics, mobile dentists, mobile diagnostics. Are there funding schemes within the current health systems that could make this happen? And how could this actually improve health service delivery in these rural and remote areas? Then funding, well, all this comes with, of course, financial consequences. So you need to have to mobilize the funding to invest in technological and digital advancements, including digital communication between health and care providers. Invest in hardware also for better and more efficient health services delivery. This can be as simple as provide reliable internet. I mean, this is still a challenge in some areas in the European region. Well, invest also then in the mobile clinics and the pharmacies and the diagnostics. I mean, they cost money, obviously. And tap into available funding sources, including at EU level, to focus also on the most vulnerable rural communities. And you can think of the Recovery and Resilience Funds, for example, but also cohesion funds and funds in the Common Agricultural Policy or the rural areas policies. And under the other, there was a whole range, of course, but awareness raising among policymakers, like this is a problem. You should actually concern yourself with this topic because the health inequalities in your country are increasing and you do not want that. But also awareness raising among the citizens that this is a problem, and that also to some extent they have to deal with the fact that they may not be able anymore to access the health or care worker that they would really like to see. And also support citizens in their navigation through sometimes very complex health and care systems and procedures. Increase the role for local authorities, so more decentralize some of the decision making, also on funding. It's a very difficult topic in some countries. For example, in Serbia, they said we are adamant to establish a task force on medical deserts at the national level that will be able to really focus on this topic and tackle them. Much more to tell about that, but I'm not going to do that, and I'm going to stop here. Thank you so much.
Okay, thanks, Corinne. Interesting, the approach, consensus building process. You talked a lot about it. My only simple question, I don't see questions in the chat, so I'm asking now my own questions, but please do if you have any questions on the solutions. Oh, there is a hand raised. Okay, that's of course interesting. But let me ask my question. Who should take the initiative of this consensus building process? Because that's the tricky one. We will not have these GP practices starting up this process. They are far too busy. So who should be most entitled to start this process?
Yeah, you're too sharp, Diederik, because that's an excellent question. I mean, we had this project behind us and had the resources and the time to do so. What we tried to do in our sessions was to try to instill upon the participants the realization that anyone could actually start this process. That's very easily said, but more difficult to do, actually. You would want in the Netherlands, we have at some point talked about we should have some kind of an envoy, on a special envoy on medical deserts or on health access inequalities that could actually do or stimulate this kind of discussions. I'm also a big fan of the Burgerraad. I'm not sure how you would...
Citizen Council.
Citizen councils, yes, thank you. That is being implemented in several municipalities in the Netherlands on different sorts of topics. That this could also lend itself very, very nicely to. And I've also hinted at in several local municipalities where I had contacts to start something like that. But it's a very good question, and I cannot give you a definitive answer.
Thanks. Zoe Parker, if you open your microphone and your video, that would be great. Thanks. Floor is yours.
Yeah, hi, thanks for this presentation. Really interesting. I just had a question regarding, like, more considering the patients and the reach of patients in these medical deserts. When you have, like, all of this digitalization going on and everything, that's great. But how would we deal with more vulnerable populations that actually don't even have access to, like a computer or proper internet, like you said? What do you think is the solution here?
Yeah, a very good question, and it's not a one-off solution. There would be a set of solutions or avenues that you should have to explore. Internet is, reliable internet. It sounds like, we are so used to having it, but it can be vital, especially if you want to rely more on digital solutions. The other aspect that we also talked about a lot is, can you not build patient or community support groups where people help each other in getting access to or using the digital tools, getting access to digital platforms, for example. If you have patient platforms, or you can log into your GP practice and request repeat medication, for example, and people are scared of digital devices and stuff like that. Can you not build support groups where people help each other? And what I found, and I found that in the Netherlands, but I heard it also back from my partners in the other countries, is that we should not underestimate the resilience of communities in these areas. They know each other. They know each other's parents and grandparents and families, you know, so they can be a quite tight-knit society. So it shouldn't be too difficult to actually start organizing that.
Yeah.
Okay, thank you.
Adding to this, Zoe, I think we always, as a EFPC, say, well, social cohesion is crucial.
Yeah.
And my former chair, Jan de Maaseneer, always said, well, primary care can contribute to social cohesion very much. But that brings again to the face-to-face needs. You need to know each other. People will not know each other from digital communication channels. Might be a little, but the real thing is, and in these regions, that people know each other from the street. I mean, that's where it happens. So I think that's crucial to keep in mind. I have, and then I give the floor to Peter, but I have a very short question, but it's a big one. If you say we have to increase numbers, then I always say, and we have discussed this before, Corinne, I think, we might also decrease numbers in the sense of medical needs. You touched upon a little, but I think the rising needs of everyone, we will not keep pace with increasing numbers of workforce. And this goes beyond the medical deserts, of course, but it is an issue, I think. We will never reach those levels which are needed.
Yeah. And what's your question?
The question is how to decrease the numbers in the medical needs. I mean, I think we should do something.
Yeah, absolutely right. No, we did discuss this before. Yeah, for the audience, Diederik was in the advisory board of this project, so we have discussed these issues before. A two-pronged answer, to be short. The need for prevention very much came up in all the countries, in all the policy or consensus building dialogues, because it's obvious that we cannot cope actually with all the demands that citizens have on health and care systems. That was not within the remit of this within the scope of this project. Actually, the terms of reference. I mean, this is a very weak excuse, but the terms of reference for these calls was this is about medical deserts and about insufficient access to health and care workers. So and because the topic is so large, we could not also tackle that one, so to speak. What we did, and I said it very quickly, I think in a short sentence somewhere, like that at some point you have to convince people, for example, to start with in medical desert areas, that there comes a time that all their needs will not be met, because I mean, we simply can't. we don't have the money, we don't have the people, we don't have, well, whatever, you know. So, and that brings you back to the resilience of communities also. Like, okay, so how can you improve resilience, including in the health resilience of these communities? That could be more prevention, but that could also be other sorts of support systems for the population. Very quickly, yeah.
Peter, and in the meantime, I see that in the chat box, all the other 3 EU projects are mentioned, so there you can find some more information. Peter, what was your question? Go ahead.
Yeah, it's also true. It's a fantastic presentation. And also about the solutions, you see, community-oriented primary care, I hope, is a new way of tackling the problem, raising the resilience in the community. I didn't hear mention artificial intelligence. I agree very much with Corinne that there is no way that we are ever going to meet the future needs in healthcare. So AI may be we may have to force, but I'd like to hear your opinion about that. May have to convince the people that they really have to use AI before even entering the healthcare system to solve at least some of the problems already. And then there is, and I think it's at 5 minutes to 12 because also the doctors, I speak to doctors who come to because of the recertification, and they have to make a 5-year personal development plan, and they're desperate. You see, they only see more work, there are no more people, and so they're desperate. So we have to somehow, I think, put the urgency to the politicians. And I remember having been invited once in Germany about desertification. You see, they have this rural problem in Germany, and they didn't have a clue why it was reasonably successful in Holland. So I had to tell them, and actually it was quite, for me, also discovery that in Germany the politicians think the training of doctors is something that they should pay themselves or the insurance company should pay. So they don't pay that, and so it's not very attractive, and so they don't have doctors there. So what they did is they put up big billboards, go to a rural country, we need doctors there, you see, which is totally ineffective. And the thing is that they should have a political commitment. So this is very true what you said, get the politicians and everybody around the table with this urgency. And even then, with all the respect, the problem will not be solved. I think there will be more desertification. And so my question actually is, how much can AI also add to this?
Thank you, Peter. I already see that Diederik posted in the chat the webinar on advantages and challenges of AI. This is a very interesting topic because AI was mentioned every now and then. Like, oh, wouldn't artificial intelligence be able to help us? Question mark. Move on to the next topic because we don't have the answers. I mean, the people around that table at that point in time didn't have the answers. Like, oh, yes, this could be promising, but we have no idea. Let's park it for a while. But yes, at some point, this should become more important. So can't answer that question. It didn't come up in that specific formulation, so to speak.
Let's see on the 18th of July if Florian and colleagues from Austria have some answers for you, Peter. If you are not yet on holidays, you should join.
I'll probably be in Iceland by then. But...
Okay. Well, but we are running out of time. It's 2 minutes past our planned meeting, and people are leaving already. I think this was, for me, very interesting. We got a good update on what has been done on medical deserts in exploring what is the problem and what are possible solutions. So if you want to get in touch with Corinne or Linda with AHEAD or ROUTE-HWF Workforce, it's very much welcome to approach them. Can be through the EFPC or directly. As I said in the chat, the webinar, the video will be available on our YouTube channel. So then you can have a look, and if necessary, we can also share probably the presentations as such. So that's it for now. Indeed, 18th of July, the webinar on AI. And if I am right, but Robin may correct me, on the 13th of July, is it? No, it's another one. When do we have the...
It's the 4th of July with Ludmil, and then the
4th of July on Be Well, on the skills, digital skills, also on and green skills in primary care. So hope to see you there, and otherwise have a nice day, and maybe see you in Ljubljana on at our conference. Peter, would be nice. Ciao, ciao.
Thank you for having me. Ciao.
Bye-bye.
Bye.
Bye, thank you.
Shall I end the meeting, Diederik?
Yeah, I'm also
Okay.
in the meeting, but there is still somebody there. I will come to you.
Okay.
You make sure that it is recorded, that it's somewhere
Yes.
saved.
Yeah, yeah.
Okay, wonderful.